Now, the hardest ones are the patients that are dislocated. Either they used to dislocate or they actively dislocate. If you're an active dislocator, you definitely want to make sure that you're not just adding the patellofemoral replacement. And there are various options, but again, like I told you, the Arthrex one is honestly my favorite one for its versatility, but also the fact that you're not having to constantly customize everything. I mean, those are great in certain cases, but most of the time you can get away with the standard sort of options that are given. And again, you have to make sure you understand the concepts. So the idea is when we do this, we resurface the trochlea. So basically just the groove and just the patella are done. And in that case, we can get people really stable who already have dislocations. Something I'll add is something called an MQ-TFL reconstruction. And the reason we do this is to add the extra level of stability. And I'll be honest with you, even patients with high TTDGs, slight alta, with this implant and the MQ-TFL reconstruction, I can generally get them stable. Occasionally, if they have a really dislocated knee, like the person I talked about previously, sometimes we add something called the tibial tubercle osteotomy where we shift the knee over. But again, that's pretty rare. If I would say that out of 10 patellofemoral replacements that I do, 1 or 2 get an MQ-TFL reconstruction, and maybe 1 in 10 to 1 in 20 need a tibial tubercle osteotomy. The thing about this implant is essentially you can do most of the work with the implant itself. You can change the groove setting. You can change the rotation of the patient. So they can stay quite stable. And so it's very infrequent you actually need to add more things. This is a common misconception.